Right, welcome everybody. We're going to kick off this session. So it's a mixed MEN, multiple endocrine neoplasia, and SDH, which is succinated dehydrogenase, disorder session. So you're all in together because there are commonalities, and I think Steve is obviously going to explain a little bit more about that anyway. But we're very lucky we've got Steve Ball here today, who is now in Manchester, previously of Newcastle, but he's now sort of heading up the team here in Manchester. So he's going to talk to us about these conditions. Thanks, Steve.
Welcome to Manchester, where I've got to move. Sorry. So there's some house rules because I can't stand still and talk at the same time. But I've been given a zone of comfort, and it extends to about here, and about here, and about here. So you're going to get. So he's going to get really irritated with me. So I think I spoke at this event 2 years ago, so I'm a bit nervous because that means you've heard all the jokes before. So I was making my slides last night, and my wife said, "What's the talk about?" And I said, "Men." And she said, "Why is a man talking about men? You should get a woman to talk about it." So what we're going to talk about today is an overview of MEN syndromes and SDH-related conditions. And we're going to talk a bit about what they are, what causes them, how we manage them, and some of the challenges going forward. And I hope that rather than give an answer to everything, it's really providing a platform for the rest of the day, because we're going to be here all day, and maybe some of the things that we hear about this morning and think about this morning will deliver us to a position where we're going to ask questions and interact a bit later on. So I need some house rules. My mum used to say, if there's anything worse than one doctor, it's two. And if there's anything worse than two, it's three. Because they never say the same thing. Even when they do say the same thing, they don't mean to. And it's just a waste of time. And so I became a doctor, obviously. The reason I say that is, some of you with the conditions, or with relatives and loved ones with the conditions that we're going to be talking about this morning, will be looked after by some very eminent, very clever people who may use different words to the ones that I'm using. If I say something different to them, it may be because I really mean to, or it may be because I'm just using a different word. But that's a common theme that we'll revisit towards the end of the discussion, because communication between people is really important. And when people hear different things from different people, that causes a disconnect, and that might be one of the themes that runs through the rest of the day. So if you hear something that's different, I'd rather we stopped and said, actually, that's not what Professor Thacker says, and talk about it then. It may be that we can unpack it really quickly and move on, because we are meaning the same thing. So, MEN1 is what it says on the tin. One of the themes you'll hear me talk about is that medicine uses terms in a way to stop other people understanding what we mean. Because the power's with us and we don't like actually giving the knowledge and information away. So MEN1, multiple endocrine neoplasia type 1, is an autosomal dominant familial tumour syndrome. Autosomal dominant means that if you have it, there's a 50% chance that one of your children will inherit the same condition. Runs in families, and it causes tumours. It's pretty much the Ron-Seal one-coat varnish. It's what it says on the tin. And it causes problems in specific areas. Pituitary tumours, parathyroid adenomas, pancreatic neuroendocrine tumours. And then there are some smaller print things that people tend to skip over. Quite commonly causes problems with the skin as well. And actually that's one of the very characteristic features people who have the condition are aware of, but doctors who look after people often aren't. So you get things called angiofibromas and cholangiomas and lipomas. Foregut carcinoids can occur in MEN1 as well. and there's an increased risk of adrenal tumours, which are generally benign. There's a little bit of a question mark around this, because of course people with MEN1 get scanned a lot, and when we scan people in 2017 we're going to find things. Benign adrenal tumours are actually really common, so the question is it really increased in people with MEN1, or is it just that we find them more often because we scan people more? Probably is more common. So the 3 P's is what everybody grows up actually remembering: pituitary, parathyroid and pancreas. And those of you with MEN1, it will be those 3 areas that the majority of your surveillance programs are targeted towards. So how do you make a diagnosis of MEN1 in 2017? Well, there's good old school clinical medicine. If you've got 2 conditions out of the 3, pancreas, parathyroid and pituitary, we can make a diagnosis like that. If you have a family member in whom a diagnosis is already made of MEN1 and you get one of the conditions, then the chances are that's what you've got too. Or we can now in 2017 increasingly tell you you've got MEN1 because we find you've inherited the gene that another member in the family who has MEN1 has an abnormality in. So we discover we've got MEN1 not because we've got an MEN1 related problem, but because we're told we've inherited that gene. You might not even have a problem, but you're at risk of developing one. So what should you have done to you or for you, or perhaps the words we should be using is with you, in 2017 if you have that label of MEN1? And this is where we start to run into issues about different practice over the UK. And this is where we have to introduce this term of guidance. Guidance is what's meant to guide you and the clinicians who are looking after you as to what package you should have to look after you or to help you be well in 2017. Anyone watch Pirates of Caribbean 3? So there's a moment in Pirates of Caribbean 3 where there's pirate rules. Yeah. And someone says, are these rules? And he says, no, actually it's more like kind of pirate guidance. So these are rules that we're prepared to break quite a lot. And so what you might find is that not everybody in the room who has MEN1 gets this package. There might be a good reason for that, or there might not be a good reason for that. But unless we're all aware of what we should be getting, we can't make informed choices and push for the standard of care that we should be looking for. So the Endocrine Society, which is predominantly United States based but with a world view, last wrote guidance in 2013-14 around what people with MEN1 should receive in terms of their healthcare package. And it's particularly ironic this week that an American-based organisation talks about what people should get with a pre-existing medical condition when we've just excluded 28% of the American population with a pre-existing condition from health insurance coverage. I'm not a fan. So it makes general recommendations. It makes recommendations on genetic testing, when it should be done and to whom, how to screen for the tumours that people with MEN1 get, and issues advice on how best to treat and manage those tumours when they occur in people with MEN1, covering parathyroid, pancreatic, neuroendocrine tumours, NETs, pituitary tumours, and the rest. And this is all available online. It's very clear, very transparent, and it's actually quite readable, although quite thick. So, and we'll be covering this again this afternoon. This is, well, how do you assess what you should be getting? Is it really important? Do people feel really strongly we should get this? Do people feel it's kind of reasonable, but we don't feel that strongly about it? In other words, how do you weigh up evidence? Because this is an evidence-based guideline, as opposed to historically, we used to have eminence-based guidance, which was Professor so-and-so thinks this is what you should have, so this is what happens. So the way that the Endocrine Society team evaluated the evidence is depicted here, with a number and then some crosses. The number 1 or 2 that you'll see, if you see a number 1, that means we strongly believe this. The number 2 is we suggest, right? That's about the strength of feeling, which has got something to do with emotion as well as how important it is. The number of crosses from none to 4 is a depiction of the level of evidence there is to support that. So if you see 1 with 4 crosses, that means everybody feels really strongly about this and there's tons of evidence that that's the right thing to do. If you see a 2 and no crosses, that means we're a bit iffy about it and there's no evidence to support it at all. The things you should be really wary about aren't those. It's the number 1 with no crosses, because that's people feel really strongly, but there's no evidence for it at all. That's the way that most medicine's been practiced historically. So, rule number 1, or recommendation number 1, patients with MEN1 should be managed by an MDT. That's a multidisciplinary team. People don't feel that strongly about it, and there's not a great deal of evidence to support that statement. But some. But of course, one might ask, as we're in Manchester, which team? And who's in it? And how do they work together? It makes a recommendation as to who should be in the team. Endocrinologist or a gastroenterologist, oncologist, endocrine surgeon, pathologist, radiologist, and a clinical geneticist. Makes recommendations on how we should screen for the tumours that can occur in people with MEN1. MEN1 patients and their relatives identified as having the mutation causing MEN1 should be offered a combined screening program, which involves clinical assessment, biochemical testing, radiological assessment, and it gives some guidance on the nature of what those tests are and the frequency and the timing of them. And the frequency and the timing of those radiological investigations, I suspect if we did a poll around the UK, would be the ones that has the greatest variation from place to place. Some people have endoscopic ultrasounds, some people have ultrasounds, some people have CT scans, some people have MRI scans, some people don't have anything. Some people have them every year, some people have them every 3 years, some people have them every 5 years. And the guidance allows some flexibility based on local resources and choice. And patient preferences. Why is patient preference important? Anyone had an endoscopic ultrasound? Yeah. How often would you like to have one?
Not too often.
Yeah, right. So the American Endocrine Society feels most strongly that that's the level 1 evidence that that's the best test. But patient acceptability is really low. Would I want to go through an endoscopic ultrasound once every year? No, thank you. Unless I really had to. So there is some flexibility for preference and local resource. Genetic testing is probably something which we're becoming more similar in terms of our approach in the UK over the last 10 years, but for which there may still be some variation. Genetic testing is advised as important because it helps confirm a diagnosis, identifies carriers of the mutation in the family members of the person identified as having the condition, and that allows access for them to a longer term surveillance program aiming to pick things up before they become a problem. And of course, its real utility, I could say, is it allows people to be screened out. I have 4 children, I have MEN1. There's a 50% chance that each one of those children will have inherited my condition. Do I put them all through a surveillance program, or do I do a genetic test that means that I automatically know which ones don't need to have that program? So its real help is in screening out people who don't need to have the surveillance package going forward. And that reduces the anxiety within the family. Although I have to say that some families find the choice of going through that very difficult. And I've looked after families, for instance, who've chosen not to have genetic testing in their children because they don't want the moment of, why's he got to go to hospital and I don't? So they'd rather they all went to hospital until they're of an age where they can make independent choices. So again, this is about dialogue, this is about people having a preference, this is about really having a shared decision around how to approach that. MEN2 is another autosomal dominant familial tumour syndrome, but with a different package of contents. Medullary thyroid cancer is the commonest one and the one that we worry most about. Parathyroid adenoma is the same. Adrenal pheochromocytoma is something else we worry about. And like MEN1, there are some cutaneous features too. MEN2, although it's got one name, it's actually got 5 different diseases within it, all of which have some things in common, but then with a little bit of an add-on. So the classic MEN2, which is 90% of people who have it, they are at risk of medullary thyroid cancer, pheochromocytoma, and hyperparathyroidism. MEN2 with cutaneous lichen amyloidosis, which is a really long name for large brown patches of skin, which can be itchy and can cause discomfort. MEN2 with Hirschsprung's disease, which is relatively uncommon and rare. Familial medullary thyroid cancer, which is again the Ronseal one-coat varnish name. You just get medullary thyroid cancer that runs in families, and you don't get any of the other manifestations of MEN2. And then familial medullary thyroid cancer with Hirschsprung's disease. That's quite rare as well. So one name, 5 independent diseases, all of which are linked with common features. MEN3, which historically has also been called MEN2B, and we're all thinking of it, so let's just not go there. It's like MEN2 but different. It's more rare than MEN2. The clinical features of medullary thyroid cancer and pheochromocytoma from an endocrinological perspective, the penetrance or the chances of you getting medullary thyroid cancer are much higher in MEN3 than in MEN2, and the chances of you getting a pheochromocytoma are higher as well. But you don't get hyperparathyroidism. You do get ganglioneuromas, which are swellings of the nerve endings that can occur on your mucosal surfaces. You get them in your cornea, on your tongue, and the ones you can't see, but often actually cause the most problems, are within your gut. So like MEN2, but different. MEN2 and MEN3 have been a real, what you would call, paradigm in molecular medicine over the last 20 years, they've been really at the forefront in the development of a completely different approach to how we do medicine. Because they are probably one of the best, if not the best example of how genetics has really changed how we manage and help people with conditions. MEN2 and MEN3 are invariably associated with a mutation in one gene, and that gene is called RET. MEN2, 95% of patients have a mutation in RET affecting exons 10 or 11. Those are the bricks that make your gene up. So in brick 10 or brick 9, there's a mutation. MEN3, your mutations in exon 16 or 15, and in familial medullary thyroid cancer, exons 13 or 14 generally. So we're going to talk a little bit about this over the next 5 minutes, because this is what's really changed over the last 20 years. So what does RET do? And why does a problem in the RET gene cause people to have tumours? Well, this is the membrane around one of your cells. Let's call it a cell in your adrenal medulla, or in your thyroid, a C cell in your thyroid that normally makes this hormone calcitonin. And stuck in the cell membrane of one of those cells are these RET molecules. Now, RET is a signaling molecule. It's a switch. What it's meant to do is sit in the cell membrane of that cell, sense something in the bloodstream, and then signal to the cell to do something, turn on. It's a switch. Like any switch, any light switch, any switch that does something important, and we'll show you that actually what RET does is control how fast your cell grows and divides. Anything that's that important's got a really good on switch, but it's also meant to have a really good off switch. You don't want your light on when you shouldn't have it on. The way that these RET molecules signal is that this outside bit here senses something in the bloodstream, and this inside bit then triggers a signal that goes into the rest of the cell to do something. How does something attaching here turn on this inside bit? Well, it does it because it causes two RET molecules to come together and form a dimer. It's called a dimer. And when those two RET molecules dimerize, something fundamentally happens to this inside area. You get a change in the structure of it, and the light switches on. And that signals something to the inside of the cell. Do something with this. In a different part of the cell membrane, the same process goes on, but triggers a different signaling process. But ultimately, they both lead to your cell cycle being turned on. That means the cell divides more and grows more. Now, in tumour biology, signals that cause cells to grow faster and divide more are the ones we worry about, because those are the molecules, or those are the signaling processes that when they go wrong, your cell's being permanently stimulated, permanently told, divide and grow, divide and grow, divide and grow. One of the characteristics of tumour cells is that they divide and grow, divide and grow, divide and grow. So you don't need to be a rocket scientist to figure something goes wrong with this on switch so that it's on all the time and can't be switched off. That cell that's got that problem, divide and grow, is going to do exactly that. It's going to divide and grow, and that's going to cause the formation of a tumour. And that's exactly what happens in MEN2 and 3. Because the mutations that occur in RET, in MEN2 and MEN3 do one of two things. They either make the RET molecules in the cell membrane able to dimerize and switch on the downstream signaling cascade, we call it, even when the signal to do so is not there. So that's like the lights on, even though no one's pressed the switch. Or in MEN3, in most cases of familial medullary thyroid cancer, that signaling process is switched on even when the RET molecules don't dimerize. So the normal control processes that regulate this switch are bypassed. And there's nothing that your cell can do to control this signal that it's getting to grow and divide, grow and divide, and grow and divide. That's what all the mutations in MEN2 and MEN3 cause, one way or another. Signaling because the RET molecules dimerize when they shouldn't, or signaling even when the RET molecules don't dimerize. Normal control processes are just bypassed. And there's not a lot we can do about that. Or is there? So there are various things. So I normally call this the Jordan rules moment. Jordan rules are just because you know something's going to happen doesn't mean you can do anything about it. Everyone wants to know why it's called the Jordan rules. It's called the Jordan rules because of Michael Jordan, basketball player. 1 minute to go and the Chicago Bulls are down by 2 points. You know exactly who's going to get the ball. You know exactly what he was going to do, but there's nothing anyone could do about it. So the utility of molecular biology in medicine's a really good thing to ask, what about the Jordan rules? So we know about this, what good does it do? Well, we're now going to talk about what good it does. Because it turns out that some of the mutations in MEN2 and MEN3 that cause that signaling process to go wrong, they make it go wrong worse than others. And so you can imagine there's a switch that is switched on and the cell gets a stronger signal to grow and divide, grow and divide, and grow and divide. If you look at the age at which people get medullary thyroid cancer with MEN2 and MEN3, they all don't get it at the same age. And actually, the age at which they get it, it turns out is predictable on the basis of the mutation in that RET gene. You get people with MEN2B who get it very young with a specific mutation. Group of people who have a mutation that gives them medullary thyroid cancer at a young age, but not as young as MEN2B. And then a group of mutations where you get it at a much later stage in life. So this is now information that means that we can tell when you're likely to get your thyroid cancer dependent on a gene test that we can do early in life on a blood test. We know that life without a thyroid is doable. And so that really opens the door to, well, if we know you're at risk of getting this thing, and we can actually predict more or less when you're going to get it, the Jordan rules moment, what good does that do? Well, the Jordan rules would suggest, well, why don't we take your thyroid out before you get medullary thyroid cancer to stop you getting it? And all of a sudden you're into disease-modifying surgery or disease-preventing surgery. And that was a unique moment in medicine. This was probably the first time we'd ever really been able to say, on the basis of a genetic test, we're going to take someone who's absolutely well and take their thyroid out to stop them getting something later in life. And that's what we now do. Based on the inheritance of the RET mutation in a specific family, we stratify people into risk levels 1, 2 and 3, and as you can see on the slide, that dictates when we suggest people have their thyroid gland removed. If you have MEN2B or certain mutations like the ones you get, in MEN3 or MEN2B, we would like to have your surgery at a very early stage in life. Now that's a really scary moment for a parent. This is someone like me coming along and saying, we want to take your well child who's 1 or 2 years old, take them to theatre and take their thyroid gland out. That's generally a bit of a moment. Risk level 2, surgery less than 5 years of age if we can. Risk level 3, we're much more relaxed. Now, one of the implications for things like this that we have to grow up and have an adult debate about in 2017 and beyond is not only in the north of England, not only in England, not only in the UK, but actually probably in Europe, dare I say, we need to ask the question, how many surgeons should we have operating on 1-year-olds' necks? And how many operations would you like that surgeon to have done on a 1-year-old before I would let my son have it done? And where we really need to start to have these grown-up conversations. Because we're not going to be doing many of these in England. We're not going to be doing many of them in the UK. We're not going to be doing that many of them in Europe, actually. How many do you need to do to be good at it? Yeah. We need to start asking these questions. So, finally, familial paraganglioma. This is a really good example of medicine coming up with a term to stop other people understanding what we're talking about. Familial paraganglioma, what's in the name? Para tells us where it is, it's close to something. Ganglia tells us a bit of where it is and a little about what it is. And oma, a little bit more about what it is. So when you have oma at the end of anything, the implication of that is it's a benign tumour. A ganglia is a collection of nerve cells, and para just means close to. So these are benign tumours made up of collections of nerve cells or things near to collections of nerve cells. Actually, they are collections of nerve cells. And they occur at characteristic parts in the nervous system. You have an automatic nervous system that you're not in control of, which has 2 parts, the sympathetic part and the parasympathetic part. And these paragangliomas occur in either one or the other of those nervous systems. The majority of those nerve cells and the paths involved in those nervous systems are in the neck or the abdomen, and that's why people tend to get paragangliomas in those 2 places. We used to think this was really rare, and this is something else we'll pick up later. We used to think it was really rare because if you looked at the different clinics in which all of these patients were, you'd find some were looked after by vascular surgeons, some would be looked after by endocrinologists, some would be looked after by ENT surgeons, some would be looked after by neurosurgeons. And each of those groups actually had a different name for this condition. And it wasn't until someone took a step back and said, actually guys, I think you're talking about the same thing, that actually all of a sudden we realised this is much more common than we thought it was. It's still rare, but much more common. And there are, I say, in 2017, at least 5 types. These are the ones we know about, PGL 1 to 5. There's probably going to be more than that because this area is still in its relative infancy. They're each associated with specific problems in specific genes, and Scott will be talking a little bit more about this later. So I'm just going to skip over this because unlike MEN 2 and 3, we know much less about what specific mutation will result in an individual. And again, one of the themes that we'll bring up, I suspect, this afternoon is that what have the Romans ever done for us moment. One of the things that the Europeans are much better at than medics in the UK have historically been is sharing information with each other and working collaboratively. And it's only really over the last 5 years, or even less, that we've got to a position in the UK of actually understanding how to work collaboratively, so we share information, and suddenly we're beginning to now see patterns emerging because we have enough information on enough families to say maybe we don't have to treat everybody exactly the same with this condition. Maybe we can be much more accurate about your life-term chances of developing a paraganglioma and where. And it's only through that kind of approach that we'll refine how we do things going forward. And Scott and people like Scott and with Scott's team, where you collect large numbers of patients to begin to then see patterns emerging that will inform how we help people going forward. So one of the things I want to finish on now is actually just, we've talked about effectively 3 different conditions, but they've actually got much more in common than they have difference. They all involve lifelong surveillance. That's not a neutral thing. That's the surveillance package for MEN1, for instance. This is a complex, boring, hard work thing for someone to have to go through every year or so. They're all inherited. Multiple members of the same family can have the same condition. Are all members of the same family going to be looked after by the same clinical team? If they're not, what do you talk around the dinner table? That's not what I was told. Well, that's not what I'm having. It's a long-term condition. The impact of the surveillance package is not neutral. Is it a day off work? Is it a week off work? Is it an afternoon off work? You've got this complex, long-term interaction with health services and professionals, all of whom have different styles, communicate or don't communicate in different ways. Do you make shared decisions, or do they just tell you what to do? Continuity, trust, all of these things are important. This is a lifelong condition that's just not neutral. How much of an input can we have with patients into how to shape services going forward? You will all have experienced different service configurations. How do we engage with you as a community to actually listen to what it is that works best for you? And I'm sure we'll have some opportunities to talk about that as the day goes on. And I'm sorry I've talked too long. Thank you.